Hello, everyone. We're here for our second episode of Sambai Speaks. And Sambai is our new project that we're working on with Dr. Melissa Davis. We came to you guys a few weeks ago and told you all about what we're doing. And now we're going to spend the next few episodes talking about every part of this research project that we're doing. We're so excited to be doing this work and really looking at the disparities for breast cancer, for prostate cancer, and for pancreatic cancer. Really in several countries, in the US, in Canada, in the UK, in Ghana, Nigeria, South Africa, Ethiopia, and Kenya. So we're hoping we have some viewers from across the pond. You know, we're in the United States, but we are just excited to do this work, to understand why our cancers are different from white people, and to lay some foundations on understanding all the disparities that we're dealing with in research and find some solutions for this horrible disease named cancer. So I'm here with my friends from our first work package, and I don't even know what a work package is, so you guys can explain that when you scientists. We have these brilliant scientists on the phone, Dr. Lauren McCullough and Dr. Tiffany Carson, and then Tia Tomlin Harris, who's on our show all the time on The Doctor Is In, but she's now with us here, and with Uza Atameka. And we are really the patient advocacy team. And our role in this project is to help regular people understand this science in words they can spell. So we brought these brilliant brains together to help us understand the work that we're doing. So I think it'd be great, Lauren, if you could just set the stage and give like the 2-second version of what Sambai is for us to refresh people's memories, and then we'll get into exactly the work that you guys are doing.
Right. So Sambai is our team, and we are challenged with addressing cancer inequities globally. And what these team awards really do is to bring together scientists working across disciplines with different approaches, even across nations, to really address some of the big questions that I think plague us in the scientific community. And so by having population scientists like Tiffany and I work hand in hand with basic bench scientists like Dr. Davis, it really provides us an opportunity to advance science in a way that we can't do on our own.
So say that again. You're a population scientist? What does that mean? Can you break that down?
Yeah. So technically we're called epidemiologists, but I thought a population scientist was maybe something a little bit, we could wrap our hands around. And so what that means is that we study the health of groups of people. So when we're doing our science, we are not just looking at one case or a few cases. We are looking at hundreds and thousands and tens of thousands of individuals to try and understand why certain groups maybe get a disease more often than others, or get more aggressive types of disease. And obviously for Tiffany and I, that group of interest are Black individuals. So it's really using large numbers and scientific techniques to understand what's happening in terms of health on a large scale.
Very, very cool. Very cool. And what's your background and what's your why?
Well, my background scientifically is that I went to Vanderbilt University in Nashville and thought I wanted to be a medical doctor, but then really fell in love with what, this population science or epidemiology, because I felt like if I wanted to have impact, I wanted to have impact on hundreds and thousands of people at a time. And, just being a provider that, one-to-one impact wouldn't sort of give me the type of career that I was looking for. And so went on and got my PhD and have been focused in cancer for almost 2 decades. And for the last 12 years have really been focused exclusively in breast cancer and understanding why Black women suffer disproportionately from aggressive disease and are more likely to die. And so my personal why is that when I was at Vanderbilt, my dad was diagnosed with cancer and, only survived like a few months. And as I sat in those pre-med classes, learning about cells and, all of these intricacies, I was wondering, like, well, what about the environment we grew up in? What about the fact that he, owned a coin laundry and was there and was exposed to environmental chemicals and like all of these things that I knew mattered for his health that we weren't learning in the classroom. And so that really is what pushed me towards population science and thinking about epidemiology. And then my why continues to be, my family. My dad had 5 brothers and sisters, and including him, 4 of them have been diagnosed with cancer along with his mom and dad. And so it has woven itself into the very fabric of my family, and, extended family, friends. And so that is always a motivator for me, just remembering his story and my experience with him, but then also, I don't want other people to have that be their lived experience, to lose a parent, lose a sister, so early, right? It's really to save lives.
Yeah, awesome. How was your dad when he died?
50.
Wow, so young.
Yeah,
So young.
very young.
So young.
Yeah.
So Dr. Tiffany, tell us about you and your why and where you're doing this work. And
well, thank you for having me. I love this platform and love the opportunity to just chat with this phenomenal group of women. And so, as Lauren mentioned, I'm also formally trained as an epidemiologist. I did my undergraduate work at Florida State University and majored in biology. Similarly, with an initial thought of being on a pre-med focused track. But, as things evolve and you sort of learn your strengths and areas where, you have interests that, you didn't have, sometimes those initial sort of career goals shift. I experienced a similar shift and knew that I wanted to do like something health related, but not necessarily patient care. And so I started to explore like how I could use my background and make impact in different ways, and learned about the field of public health and the field of epidemiology, and went on to get my master's and doctorate from the University of Alabama at Birmingham in epidemiology. After that, I also did some additional postdoctoral training in behavioral science. And that's because in addition to like all of the skills and things that we can learn and discover as epidemiologists, I'm also a person that's like very motivated to do something. So, traditional, very pure epidemiologists often focus on discovering associations and not necessarily moving forward to the intervention, but that information that we gather as epidemiologists often inform the intervention. But I wanted to be equipped to like lead the interventions myself too. So did some additional behavioral science training and now do, sort of dabble in both worlds as both an epidemiologist and behavioral scientist. In terms of disease focus, I actually started out as an obesity researcher, is how I would have branded myself. And that was, probably 12 or 13 years ago. I was very interested in obesity, again, because I saw how it, affects health, how it plagues particularly the Black community, and knowing that Black women have the highest prevalence of obesity in the United States was something of concern to me, and just trying to understand why. But around the same time, we also started to just get overwhelming evidence that in addition to being a disease in and of itself, that obesity is a key risk factor for several different cancer types. So probably at least 13 different cancers have a pretty robust evidence base showing risk for elevated risk for cancer based on having excess adiposity or excess body fat. So that being said, I understood that like as an obesity researcher, I also have the opportunity to impact a number of other diseases. And, cancer in particular for me also, probably everyone on this call and everyone who's watching this knows someone personally, a family, a friend, whomever, who has suffered from cancer, and I'm no different. And so, witnessing that and observing that and trying to understand my role and how I can help, improve the quality of life in communities is sort of what led me to bridge my obesity research training to also see if this can be a strategy to help lower risk for cancer development and also improve survivorship among individuals who are diagnosed with cancer. So, you know, that's my why. And going forward, you know, working with community members and study participants and patients at our hospital, these are all of the things that inspire me every single day. And I consider it a privilege and an honor, but also like a huge responsibility to lend the skills and talents that I have to, you know, my community in particular.
Wow, awesome. Awesome. I really want to talk more too about, you know, the whole emotional side of obesity and how that could lead to cancer too. So can't wait to talk more about that. So Tia,
Hey, Ricky.
my bestie, who I love so much.
I guess I'm answering the same questions, my why, right?
Yeah.
So again, thank you for always having me on the show. You know, my why is, you know, I was diagnosed with breast cancer, triple negative breast cancer under the age of 40. And when I look back on prior to being diagnosed, this wasn't a conversation that was normalized in my home, in my family's home, even in my community. You know, breast cancer was just out of sight, you know, out of mind, out of sight.
Right.
It wasn't anything that I've ever thought about. I had a brother, well, my brother, not I had a brother, my brother was diagnosed with testicular cancer, and he was 32 with stage 4, and the doctors had given him 6 months to live. And so that kind of, you know, shook me a little bit. But when I was younger, I was 12 years old in the 7th grade. I had an auntie that was diagnosed with breast cancer, but she wasn't a blood relative. And during that time, I was taking sex education in middle school, and they gave us a little shower card and talked about self-breast exams. And so hearing my aunt Linda, who was diagnosed with breast cancer, and she lost her breast, that was all we talked about in the family, all that was said. We really didn't talk about it. It was Linda lost her breast, end of the discussion. And my 12-year-old mind thinking, oh my God, what does that mean to lose your breast? I don't want to lose my breast, so I better start checking these puppies, right? So, you know, throughout my lifetime, I was doing self-breast exams, and that's how I discovered breast cancer. And then while I was going through this, you know, just talking to other women, talking to other Black women, learning their experiences, hearing their challenges and their stories and the lack of resources, the lack of information, I just said, I want to be a part of the solution, right? Because we've got to change this. And the more and more I got into it, the more and more I started to learn about the disparities and how this affects us as Black women. And again, I go back to prior to breast cancer, where was I? It wasn't a thought. I mean, you see people wearing pink in October, you see the stuff at the register where, hey, donate an extra penny, or, you know, donate, you know, the whole round your money up or whatever, but it really wasn't a big conversation. And like both of you, you know, Lauren and Tiffany, I also had a pivot in my career. You know, I worked in the pharmaceutical industry, but prior to that, I wanted to be a doctor as well, right? And then you start to learn about yourself. And so when I started to think about my experiences in pharma and working in the labs and being a chemist, and then tying that into my own personal experience as a breast cancer survivor, there was so much information that I was knowledgeable about. I wanted to be able to share that information with other people. And so that's my why. You know, I don't have children, but I have nieces and I have nephews, and I don't ever want them to have to hear the words "it's cancer" in their time. So that's my why. This is why I do what I do.
Great. Thank you. It's so great to work with you. And my Uza. And she's like trying to be the glue that keeps our team all together and keeps us on track. And I thank God for her every day.
Oh, I'm so happy to be a part of this. Like I think I said this in our first episode, but whatever comes out of this research is going to be monumental and just life-altering for all of us. And the social determinants of health that we'll get into in a little bit really like lays the groundwork for this entire project. And I think also it sheds light on where all of our sites that we'll be working in, where all of these regions are lacking, because there's so many factors that affect our health. And I'll let Dr. McCullough and Dr. Carson get into what the social determinants of health, what does that mean? How does that affect our health? Because there are so many factors that contribute to that. And absolutely behavior is tied into that as well. So I did not know your background, Dr. Carson. It was really nice to hear about your why, and you seeing that link there and wanting to be a part of the solution as well, and intervention and treatment. So really excited to get into it.
Yeah, so we're on this 5-year mission, right? I hope it's going to last longer, but that's what we're funded for right now. And you guys really kicked it off, you know, with the work that you're doing in the social determinants of health. So can you give a little explanation of what exactly are you doing right now? And what are we trying to find out to kind of kick this off and start the conversation to understand these inequities and disparities?
You want to take it, Tiffany, or you?
Tiffany looks like she's ready to talk.
Either way.
Go
So
ahead, kick us off.
sure. So again, I have the privilege of co-leading work package 1 with Dr. McCullough or Lauren. And Ricky, you mentioned earlier the whole work package, you know, sort of what is that? What does that mean? And so
Yeah.
I'm going to say that's just sort of some grantsmanship jargon.
Okay.
And it's sort of related specifically to this funding mechanism, the Cancer Grant Challenge, and that's more common language used in some of these UK-based grants. But it really is a way to sort of organize the objectives of the project that you are seeking to do. And so I'm sure you probably went through, you know, the different work packages in the first episode of Sambai Speaks, and that really gives us sort of an area of focus to coalesce around within the context of this much larger project. So our work package is really foundational to everything that Sambai is seeking to do. As population scientists, you know, our largest task was really to, well, our largest task to date was really to design the study. And this has to be done in a very rigorous and scientific way for us to have meaningful data and outcomes at the end. And so this includes, you know, sort of defining who our population will be, how many patients that we need or cases that we need for the study, how many cancer-free individuals that we need for comparisons, and really just outlining the premise of what the study design will include. And then our next sort of major task is to really capture a great deal of social, environmental, and behavioral data and clinical data related to our study participants. And so we know that cancer often occurs and outcomes are related to not only things happening within the body or at a biological level, but a lot of that is driven by things that are happening outside of the body. And so it's those exposures, those social exposures, behaviors, lifestyle exposures that we are really tasked with measuring and capturing for the entire Sambai cohort. Now, as you can imagine, the cohort will be 40,000 people across 3 different continents and 7 or 8 different countries.
40,000 people. Say that again.
40,000 people. So it's a large number of people in very diverse geographic regions. And so we are right now creating a tool to effectively capture relevant variables and potentially relevant variables across all of these different geographies.
What's a variable? Can you explain what a variable is?
I'm sorry. Yeah. So sort of relevant factors. And so I'll give an example. Income is a variable, and income is part of, you know, sort of socioeconomic status and can be a social determinant of health. Income in the US may be something very different than income in the UK, and that might be something very different in our African countries as well. And so it's our job in Work Package 1 to create a tool that can accurately measure all of these different variables or factors across these different geographic regions in a way that can then be tied to the biological data to hopefully help us understand how various cancers develop, why they develop these ways in certain populations. So it's a huge task, but I think it will result in a resource like nothing else that has ever existed, because as Lauren mentioned in the beginning, it's this partnership of population scientists with basic and bench scientists that will lead to something that's totally innovative and something that neither side could do on their own.
So it's kind of like picking, so everybody has on a red shirt. So what does that look like across populations, that red, and how does that red shirt impact their health? Or can you help me do another better analogy, like something about their person, their lifestyle or their body, maybe people who eat broccoli or something. I'm just trying to think of like something to kind of normalize it.
Yeah, so I think food is another good example, right?
Yeah.
Because we will need to capture dietary pattern of our study participants. When I say dietary pattern, that just sort of means how people eat overall.
Right, right.
But as you can imagine, just through cultural differences, people will have different dietary patterns and dietary intake across our different Sambai geographic regions. And so we need to measure that and then harmonize it to really understand how it's impacting cancer risk and cancer outcomes more specifically.
That's
Lauren,
very.
do you have another good analogy, Lauren?
No, I actually liked your red shirt analogy, Ricky, because I think, that's really simple and straightforward. And it's like, does everybody with a red shirt end up developing cancer? Well, no. Well, maybe it's a red shirt and a yellow hat, right? And so it's our job to be able to figure out what those combinations are.
Right.
And then it's maybe a red shirt, a yellow hat, and a purple heart. The heart would be like what's inside, the biology, the genetics. And so being able to figure out how all of these different pieces, work together to influence outcomes, then we can start to better personalize medicine, personalize prevention strategies, and those kinds of things. So that is essentially what it is. We're looking for the red shirt wearers. Yeah.
That's a really great visual. And to that point, it'll be interesting to see the differences that our locations bring, our locations and our cultures and all those things, but it'll also be interesting to see, regardless of those things, the similarities in the disease.
Right. Right. Or then you start looking at somebody who wears a red shirt who's obese, or somebody who wears a red shirt who has bad eating habits or something, and you kind of figure out how you put all those pieces together. But over 40,000 people, oh my God. So
that's kind of the reason why we need such large numbers, right? If we were just saying red shirt versus yellow shirt, maybe we could do that with 2,000 people. But then once you start putting in all those combinations, you can see how you get larger and larger groups. And so you got to start with a really, really big number to be able to get to that granularity. We say all the time, Black people are not a monolith, right? And so we got to have a diverse group to be able to get to answers and to be able to get to that level of specificity that's really needed to have good outcomes.
To break it down, so complicated, so simple you think, until it just becomes so complicated about all the things that you're looking at, I don't want to seem like I'm oversimplifying it with a red shirt.
And Ricky, one thing I like about this is, oftentimes we hear in our families, oh, because this person had it, this is why we have it, right? And I'm not talking about cancer. It could be, it could be heart problems. It could be, diabetes and things like that. We sometimes label it as, I got it because my mom has it, right? But it may not necessarily be because your mom had it. It could be you've inherited not necessarily the disease itself, but you've inherited the activities or the lifestyle or the foods, the diet, the products that you're using. So this research to me is going to help inform that, so we can stop using it as an excuse and saying, okay, I'm not eating healthy, or I'm not, using the right products, or I live in an environment that's, putting me at a greater risk for X, Y, and Z, health, chronic illness or health condition or what have you. But I think that's going to be good, because then going back to what Lauren said, and I always want to say Dr. McCullough, but going back to what Lauren said is, personalized medicine.
Right, which is really
what works for one person is not working for another, which is why we're having these issues now with the drugs not working for Black women or Black people, not just Black women.
Right. And I think, personalized medicine or precision medicine is kind of the way of the future. but I don't think our people are getting that. You know, we're still going to, most of us are going to community hospitals where
Right.
there may not even be a breast oncologist, it's probably just an oncologist, you know, and you're not getting the level of care and detail that we're needing to have to be able to have precision medicine or you know, something totally directed to our bodies. But I think that's what you guys are helping us get to, like what should be on that checklist of what could be happening in our bodies is kind of what I
Laser
think.
focus.
Exactly. I mean, to even take a step back from the care that people are getting when they arrive at their hospital or the choice of which cancer hospital they choose to go to,
Right.
there's a step before that, and that's actually doing the research to have the evidence to inform precision medicine and personalized medicine. And unfortunately, you know, Black communities have been underrepresented in that research. And so that is one of, you know, the inspirations, I think, for Sambai. The key goals is to make sure that Black people are very well represented in research, and that includes our survey data, but as well as our knowledge of what we know about genetics and sort of biological processes that influence cancer outcomes as well. And Sambai will be, you know, sort of uniquely positioned, I think, also to disentangle or contribute some insight into, you know, the sort of, is it all social or is it all biology? Is it all environment? And the reality is it's probably a combination of all of these things, but we need to systematically collect data to really be able to make some informed conclusions. So I think Sambai, especially having individuals of African ancestry. So there's always that shared ancestry linking everyone together, but now living in different parts of the globe because of the diaspora, we can sort of, again, disentangle what is ancestry, what is environment, what is social exposures in a way that hasn't been done before.
And this is
Right.
really going to inform, you know, when the data come out, the research comes out, it's going to help inform even the curriculum that they're using for medical schools, right? Because doctors are now going to have to make some type of pivot to really pay attention to their patients, right? To really get to know their patients. And so now when we talk about patient-provider relationships and decision-making, this is going to play a critical role in the care of each individual person.
I think that's such a great point, Tia. And also it'll help us as patients bring information to the table that they may not have ever thought of before because we were never asked what our lifestyle issues were.
Yeah.
You know, like, why are we obese? Do we have obesity in our family? Have we always eaten this way? Why did we historically eat this way? Like things like that a doctor probably never asked a patient. You know, they just said, oh, you're obese. We're going to get you some blood pressure medicine or something, right? So I think that's
allow you to be a more informed advocate.
Yeah, we'll be more informed. It's interesting too because you guys are doctors, like you're doctors, even though you're not, you know, medical doctors. You're like you are basically pursuing this craft that's very technical and detailed, and you're not just asking people what they eat. Like, how do you do your work? Like, what do you do? Like how do you talk to people to get the information you need?
Well, I mean, I think in the most systematic way, because we are talking to thousands of people.
Hundreds of thousands, right?
It's all in that survey design and how you capture people's experiences. And it's not as easy as just being like, well, what did you eat yesterday? Right. Or, you know, do you exercise? Like the detail and the granularity of trying to get this information from people it is difficult. And, you know, one of the things that we know about humans is that there is human error. And so we have to account for that error, even on the front end as we're designing our questions. And so that's where engagement with your team and Tia is going to become so incredibly important to ensure that as we're designing the surveys and thinking about the questions that we're asking, are we asking them appropriately? Are we probing in a way that's going to jog people to give us the answers that we want? So, you know, in a systematic way, that I think is how we talk to people. But I also believe as a scientist, it's really easy for us to go into our labs or behind our computers and start crunching numbers and doing things. And I think it is so important that we're actually talking to real people and not just
And
having
that's
conversations with the data.
right.
I know I personally have found it so incredibly impactful and really idea generating and stimulating to engage with women in this community. You know, I've known Tia for at least 3 years now. And so talking to people also means talking to the community about what you're doing, about your ideas, trying to figure out what matters to them. And I think that's where science sometimes hits a standstill, because oftentimes we operate in our own echo chambers and we just continue to propagate the same narratives without getting new insights by engaging with the communities for whom our research is supposed to serve. So talking to people, I think, is two-pronged in this business, right? It's through our data, but I think it also has to have that human element where we're connecting with the communities that we're trying to serve.
And that's kind of our job. I mean, right? I mean, go ahead. That's our job as the patient advocates on the team.
Right.
Go ahead, Lisa.
Oh, I was just going to add, in order to collect that data in your work, coming from a background of, I used to be in like occupational therapy, and we were all about the holistic approach, looking at the individual as a whole. So that is what you have to do. Like that, you're required to do that through your work. So you are getting the full picture. I understand what you're saying about getting lost in the science sometimes, but as far as in your line of work, you have to. So I think us starting this way, getting the full picture of the 40,000 people we're going to be working with, is the way to start. And it keeps all of us grounded in the people, the people, because without the people, there is no science.
Right.
Yeah.
Yeah, no, that's so true. You know, Lauren, as you were talking about the importance of talking with the community and sort of sharing ideas and that sort of thing, it actually reminded me of how critical those conversations were in like this expansion of my research focus into the cancer arena in general. So, you know, again, you know, living my life as an obesity researcher, I was working at UAB. The Comprehensive Cancer Center there had a sort of large network or partnership that was funded through the NCI to do coalition building and capacity building in underserved populations. And just in some of the work that they were doing and talking to people in local communities about what did they want, what did they need in their communities, what did they perceive as their needs in their communities to improve health and lower risk for cancer or improve cancer outcomes. One of the things that they talked about resoundingly was information about healthy diet and exercise and weight management. And so because of that feedback from the community, as that being something that they wanted, I remember the Cancer Center sort of reaching out to me directly to say, hey, is there an opportunity for partnership here? And, you know, sort of, are you interested in this kind of work? And, you know, it sort of started then and went from there. So, you know, I think there's a similar opportunity here with Sambai, given like the major engagement of our patient advocates and the work that you all will be doing to do, you know, sort of needs assessments and building relationships with our patient population, that we can really sort of try to meet the needs of their areas as well.
Yeah, we really are trying to build a network of organizations and support groups in all of our areas and all of our countries, so that we can have some tentacles and have partnerships to bring information to meet patients, to understand the landscape in each country, to understand the languages that we need to be speaking differently. Even the translations of what you have of your science, how can we make that, break it down so people understand it? And so that's what we're really excited about doing this work.
Yeah. Your role will really, really be critical, especially as we try to, you know, refine our measures, our surveys, our instruments, because again, to Lauren's point about, you know, the importance of survey development, it's not as easy as it sounds. It's not just asking a question. And, you know, there are a number of, you know, sort of surveys in the field that we use and refer to as like validated surveys, but validated for whom? Were people?
What does that mean? Like what does that mean, a validated survey?
So that means that it's been tested and shows some reliability, and that is actually measuring what you are wanting to measure. But again, as you can imagine, if certain groups are not represented when that testing and validation is happening, then it might be a stretch to, assume that those
Yeah.
same surveys are valid for those other populations.
Right.
And so, just we are taking the task very seriously of like crafting the survey to make sure that we are measuring what we intend to measure, and that feedback that you all get from our from the network that you are developing, I think will really help us in that area.
Absolutely. We're here to
Since you
represent.
said,
Sorry.
oh, I was going to say, since you said validated, and another component of what we're doing is doing some of our own validation for a number of things, like, the body metrics, sleep, environment, which is going to be some of the first data generated, particularly in Africa, on certain environmental toxicants and contaminants and air pollution and things like that. So a lot of the work that we are doing is going to be some of that validation that is specific for this population.
To make it different for them.
Yeah, we are here to represent the patient voice. And when we're meeting with these groups, I just told someone today, we can't do that without, we need you. We want to be one voice, but also we need your proper representation, because yes, I have Nigerian roots, but I don't necessarily know what it's like to live there right now. I don't know what that experience is for them. So we need to bring in we need to widen our family so that we can
right.
together.
Broaden our family so we can reflect everybody involved in this. And there are many cultural, we like to use the words cultural humility, learn about other cultures, other people. And so we're used to, seeing Black Americans, but now to see countries where there's majority Black, and we have, such great plethora of all different kinds of people, even within that, in the countries. And so we're looking at, not just that one monolithic Black person, wherever they are. We're looking with people with all different personalities, all different backgrounds, all different environments. And so it'll be really interesting to see how that all plays out in data that we can aggregate and tell a story about. Yeah. If you had to weave a story just kind of based on what you know now, and I know that when we all wrote the grant, you had a lot of hypotheses in the grant, kind of based on your research that you're doing already. Like, where are you seeing the story kind of going? Even if you have one yet,
Yeah, well, I can say, and my work is almost exclusively focused on breast cancer. So prostate specifically is going to be a shift for me. But, I think in breast cancer, there are two big disparities that really plague us. The first is the development of triple negative breast cancer and the whys behind that. And then the other is, this higher mortality, no matter what type of breast cancer.
No matter what, we die more early at any stage, any age, any subtype, anything.
Across the board, and so, those have been the two things that our group has been focused on. And for me, the question has been, why is it that for early stage, we're having the same mortality outcomes in terms of disparities, same for the hormone receptor positive breast cancers? And why is it that women who live in these higher socioeconomic neighborhoods have some of the biggest disparities? And that suggests to me that it is not, access, we all know is important. It's important to be able to get to a qualified health system, get good care, have transportation, have insurance. And I think that has been the low-hanging fruit in the research community. Like, oh, Black people just need to get access. But then how do you respond when you see a group of women who have access and they're still faring worse? Matter of fact, much worse than their white counterparts. And so that just suggests to me that there are other things at play, that access doesn't, really account for the experience of being in this skin, right? And trying to understand how that translates over different countries. Like, I'm really interested in understanding, for our high income Black women in the United States that live in white neighborhoods, what is their day-to-day interactions? How does that stress, how does that shifting impact their bodies? And then if you take that same framework and you apply it in one of our African countries where they live in places and interact with people that look like them all the time, how are those buffers really impacting their risk of disease, right? Like, how does being in a community with people that look like you and honor you and respect you and impact outcomes? And so I am really excited to be able to do, these geographic analyses to understand what things hold. And more importantly, like, we spend a lot of time talking about disparities and what things are bad, but what things are really good? What are the things that are helping women?
Yeah, where are the commonalities that are good, right?
Right. What are the buffering effects? What is building resilience in certain women? I'm so intrigued, by that. I was born and raised in Atlanta, and so my maternal and paternal grandmother both grew up here, and my maternal grandmother passed at the age of 62, in a neighborhood that was 10 miles from my paternal grandmother. And she's had liver cancer growing for 10 years, and she's 96 and still here. Why?
Wow.
Like, what is the difference between
Right.
these two ladies, right? And if we can quantify that,
Right.
I know there's a lot we need to do with our government and environment and all of that stuff. They're going to be slow. Like, what can we learn that can be built ground up to help
Right.
improve people's outcomes? That's what I'm really interested in.
Can you speak to those two facts that you kind of always say, and I don't want to misquote them, but basically women with equivalent insurance and their mortality rate and women with sort of an equivalent socioeconomic situation. Those
Yeah.
numbers always blow my mind, blow me away.
Yeah. So what we found in Georgia is that women who had private insurance, Black women compared to white women, Black women were 62% more likely to die compared to their white counterparts. And that's with private
62%.
62%. And then when we looked at high socioeconomic neighborhoods, Black women living in those neighborhoods compared to white women were 126% times more likely to die. So more than a twofold increase in death.
Isn't that crazy?
It blow every time I look at the data, it blows my mind. It really does.
So now we're going into situations that are more rural and with less resources, and where you may not have health insurance, you have to pay for your care. What is that going to look like to the cancer patients? Some of the countries that we're talking to, and the women that we're talking to that are experiencing breast cancer, and with a lot less advantages even in the United States. One of the things we talked about at our retreat this weekend that I just love to hear about is that, yes, Black breast cancer is a different disease than white breast cancer. And that's now finally, I think, coming to the table as clearly evident from so much science. And I'm really happy about that because the stuff we got now isn't working. So I think we need to recognize and admit that the Black woman that Dr. Melissa has been, kind of studying for years with her Duffy Knoll gene or whatever work in Ghana to show it's a different science that we're dealing with. And I'm so happy that we can embrace science is going to work for Black people wherever we are.
Mm-hmm. Yeah, absolutely. Our underlying genes are different, but probably not as different as some people like to think, but it's the things that are on top of the genes, right? Like how the genes are expressed, and that expression is based off of so many different things, including our social interactions, our diet, our environment, and so those are really keys for us in taking, like Tiffany said earlier, all these exposures that are above the skin, and then how do they translate below to impact the process of cancer. I think is something that we're really going to be able to better understand by having all the social determinants and structural determinants and genetics and, all layered on top of each other.
Yeah. And I think also from Tia's perspective too, Tia, what kinds of things are we being impacted in our environment that are different in Ghana, in Kenya, in the United States, in the UK. So all of those factors are going to play a role in how we look at cancers everywhere that we're going to study. So I'm really excited about that.
Overall, I think it's going to help us understand each other in so many ways.
Yeah.
I love that take. Like we talked about it in a very scientific way, and like all of the data that we can generate and all of that is very important so that we can, get closer to, ideally cancer prevention, but if not, then having drugs that, are effective.
Right, that
Um,
work. Hello, drugs that work, that we
drugs
don't
that
have
work.
for the concept.
Exactly. But I love that summary. It's a lot to learn about each other. And I think a lot of that will happen through this project. So
Yeah,
It'll be a ripple effect. I think it'll shed light on so many things, as we've said, expose where we're lacking and where we can maybe contribute to resources that these communities need. We have talked, and we'll touch on it eventually, but we've talked about in our smaller team, patient advocacy, can we do drives, maybe food drives, clothes drives, when we're traveling and doing visits in these communities? What can we provide to them with our resources here? So I
Yeah.
hope that.
Yeah.
we
I mean,
need
this,
more
this
comments.
this is truly big, what we're doing. I even think about just health insurance, right?
Yeah,
And the challenges that we have with that and people getting denied, and it's different from one person to the next. And so it's going to be a major shift with the data that's going to come out of this to really say we've got a
Right.
lot to change
got a
so that
lot
we
to
can
do.
really, have better health outcomes for people. Because when we look at even down to like the numbers, right? And not numbers of people, but I'm talking about the financial numbers and the impact that it's having on our economy, when we have a lot of sick people, right? What is that doing to our places of work, our employment, the school
Right.
system, children, all of these things. So I really am just excited about this opportunity and what's going to come out of this. I mean, we know the data that does exist, right? But it's not enough specifically for us.
Right.
And so, like I talked about not too long ago, with the research, my hope is that something is done and it's not just another. For us, we know we're going to do something with it, but it's on a larger scale. We're bringing forth the data, but we need to see change, right? We don't need to keep having all these different research projects if there's no change. What's the
Right.
point, right?
And I think that's the beauty of Sambai and the Cancer Grand Challenge, because
Yep.
we are being held accountable for the money that we've been given and what we're spending to do this work. And I think that, they're watching over us. We have these sort of fairy godmothers and godfathers from the UK and NIH kind of watching, do you guys need anything? Are you okay? And so I think we have this huge iconic opportunity to really make a difference and do something profound that's going to have a resounding, long-lasting, impact on cancer.
And Ricky, just like what we're doing, rallying up the advocates, educating the advocates. Now we can be better positioned to hold people accountable, hold systems accountable to make it better for us. When we don't have the data, we don't have the information, it does become a little bit challenging to hold people accountable. But like you said, with this project that we're doing, this iconic work, as you would say, it's going to help us be able to move the needle. And not just for us. We may not see the needle move in our lifetime, but it's for the next generation.
Next generation, and this may not help the patients that we're going to encounter with your cancer, but we're going to help it for your kids and your grandbabies and for the community, and just making a statement about how to make this better for everybody. And, hopefully we'll do something profound, and I know that we will. So
I think when it's hard for us as Black people not to do anything when we're more informed about anything. It's hard for us not to move and want to inflict change. So
And even more than that, one of the reasons why we in work package 1, we always say multi-level, multi-dimensional. When we think about change can happen at many different places, in many different inflection points. And I think there is very big, robust change that needs to come from systems. So, top down. But I also think it provides an opportunity to think about, like, what can we change in our own communities, right? Like, what can we be responsible? How can we be responsible for the health of each other and our children? And by having this multi-level approach, we can really sort of, again, hold people accountable for those big, robust changes, while also saying, you know, we have some control over this narrative, and what can we do within our own, you know, advocacy work. So I love that model, because I don't have a lot of trust that things will happen swiftly. You know, those big top-down approaches. And I do think that we have, again, with the information and knowledge, we have the ability to change and manage our communities.
And I think, you know, I think it is a 5-year project, but I think we're going to have these little wins along the way where hopefully we can impact information, also build relationships. Like we've been reaching out to people saying, you know, can you help us get a mammogram machine? Can you help us, you know, do screening? And I think hopefully we're going to build some really, really wonderful relationships with our new partners that we're starting to meet and encounter, and bring resources to everybody, you know, that we can. So
Absolutely.
it's exciting. I'm excited, you know. Thank you guys for being here with us for our second episode of Sambai Speaks. And we'll keep this up. We'll keep this up and keep learning and talking and more. And you guys have to come back with some of our partners that we meet along the way in a few months as we go down the road, and sort of have all the work packages talk about what their work is, so people sort of understand the foundation. But then we're going to go make lots of friends and bring them to the table and bring them to the party and talk, and just make this exchange more robust and loving, you know. And the way I look at our role is it's about love. You know how I talk about research. It's about love, because we don't really understand what's in the petri dish. We don't understand what's in the survey, but we do understand that you guys are going to do something great for us to make us live longer. What a concept.
Absolutely. Always an honor to be here, Ricky.
Thank you so much. Thank you so much. And you'll see everybody soon, right? We'll see you next month. And spread the word, show to your friends, you know, explain what's going on, and let's just get the word out there and tell more people what we're up to. But thank you, Tiffany. Thank you, Tia. Thank you, Lauren.
Thank you so much for your time. And yeah, join us as we continue to break down the science.
Yeah.
Thank you.
Blessing. Bless you, love. I can do bless you, love on your episode. This is what you guys are doing. So take care of the boobs. Thank you. Take care.
Take care.